Hello, I am Dr. Agatha Biss, and thank you for coming to part 2 of Occlusion, TMD Disorder, and Parafunction webinar. So just a quick review of part 1. We talked about function, dysfunction, and disorder, the differences between them. We went over typical TMD signs and symptoms, touched on imaging, discussed some of the typical dental appliances that are made for these patients that actually don't help them at all. And then we were talking about muscle versus joint and how to tell whether the patient's pain is coming from muscle or joint so that we know what type of appliance to make. And we also talked about bruxism, and especially early bruxism, and what type of appliance is best for this type of patient. So today, I would like to talk about treating chronic complex TMD patients, understanding the causes of their particular symptoms and signs, and the meaning of the signs and symptoms. So we're going to go through that in a lot more detail today. If you do start to see TMD patients more, you'll notice that these intraoral signs like narrow maxillary arch, narrow mandibular arch, all these various intraoral signs are really, really, really common among TMD patients. But the question is, what caused these? How did these develop? And when did these initially begin? And one of the main causes of TMD actually begins very early on in the developing child, and it has to do with airway. In a normal, healthy person, in a healthy developing child, normal breathing occurs through the nose. The mouth is closed, the tongue is sitting against the roof of the palate, the roof of the mouth, and air comes in through the nasal passages and travels throughout the body. And so if the child is healthy, this is what we expect to see. Now, if a child develops allergies, whether it's pollen or milk or any other type of allergic reactions, you typically get adenoids and tonsil swelling. And as those swell, they cause a blockage to the airway. And air is not able to come through easily. So the child inherently opens their mouth, drops their tongue, and begins to breathe through the mouth. So these are two different patients, and you can see the large adenoid swollen in this child. And then you've also got the same thing here, almost complete obstruction of the nasal passages in order to get air in. And so as this child is trying to get air in through the nose, they can't. And so the tongue has to drop and air can enter through the mouth. Now, the normal position is tongue against the roof of the palate, or the tongue against the roof of the mouth. And that position is actually what develops the nasal passages to begin with. So if you look at the relationship between the tongue and the palate and the buccinator muscle and the teeth, the tongue actually influences skeletal growth in the frontal view, so the width, and the AP dimension. So it's responsible for horizontally positioning the teeth where they are supposed to be, causing the palate to be wide and the nasal passages to develop. So the roof of the mouth is the floor of the nasal passages. So the width of the roof of the mouth influences the volume of the nasal passages. And this is important to understand. And when you start to look at your TMD patients who have narrow arches, you'll also correlate their airway issues and breathing issues and all kinds of other issues altogether. So it's really important to understand how this developed. And people with a narrow maxilla very, very often have difficulty breathing. Now, as the teeth erupt, they are moved horizontally into position by the opposing forces from the tongue and the outside muscles. So that's essentially what positions the teeth. And the anterior teeth are the same. So you've got the combined effect of the position and the strength between the tongue and the buccinator muscle and the lip, and also the posture of the tongue. And that defines the precise horizontal position and inclination of the anterior teeth. So again, balancing muscles, opposing muscles are what position the teeth in space. So a high, narrow upper arch is a result of inward pressure from the buccinator muscle and lack of outward tongue pressure. And impacted teeth or ectopically erupted teeth are a sign of a narrow arch. And I'm going to explain that in a minute. But if you take a look at the relationship that we are supposed to have, that what we want to see in our children, developing children, and in our adult patients, what we want is the palatal cusps of upper teeth, upper molars, sitting in the central fossa of the lower molar. We want teeth loaded on their long axis. We want the maxilla wider than the mandible. We want teeth surrounded by bone to ensure proper soft tissue support. So what happens to this relationship if the arch is too narrow? Well, let's take a look at a narrow arch. As a child is developing, the typical eruption sequence is centrals first, then the laterals, then you get your premolars, and then your molars, and the last typically are the canines. So if the arch is too narrow, the canines either become ectopic or impacted. So that high, narrow upper arch is the result of inward pressure from the buccinator and lack of the tongue pressure outwards. So what causes a lack of outward tongue pressure? Forward tongue pressure posture is caused by inadequate airway. So the swollen tonsils and the adenoids, the tongue is dropping, moving forward, trying to make room for the air to come in through the mouth. Forward tongue posture pushes the anterior teeth forward, eliminating the outward tongue pressure against the posterior teeth. So the tongue drops, moves forward, air comes in, and now you've got a narrow arch and very V-shaped pointy jaw. Tongue drops, you get narrowing of the upper arch, and it will either cover the posterior teeth or push forward. If it covers the posterior teeth, you'll typically get lower anterior teeth over erupting. And as the child closes, this person closes, they hit prematurely, and the jaw has to slide backwards in order to bite down on the posterior teeth. That results in disc displacement, clicking and popping, and subsequent TMD symptoms. So that retruded jaw position is a result of this bicuspid drop-off, the tongue covering the lower teeth, preventing the posterior teeth from erupting, lower anterior teeth are over-erupt, and now the jaw has to slide back in order to accommodate this new tooth position. As the jaw slides back, it causes obstruction of the airway. So the only way to get the airway to open again is for the patient to slide their head forward, so forward head position. As they slide their head forward, the tongue moves out of the way, but now the neck is strained, and so are the neck muscles, shoulder muscles, and head. So a retruded mandible leads to forward head posture. Now, a normal head weighs 10 pounds or so, and the force at the fulcrum is measured by weight and distance. So if you move your head forward, the weight at the fulcrum increases. And you go from 10 pounds to 40 pounds, which is why most of these patients have neck, shoulder, and back pain. So when the tongue drops, it no longer provides balancing forces for the buccinator muscle. So the teeth tip in, and you get a narrow upper arch. Now, what happens next? It depends on what the person does with their tongue. Sometimes you get exactly that. You get a crossbite. So teeth tip in from the buccinator muscle pressure, and you just get a posterior crossbite. Sometimes it's bilateral, sometimes it's unilateral. Sometimes you get what's called a bimaxillary convergent. So if the tongue pushes forward, you get more forces from the buccinator, and you get teeth tipping in, both of them. So they may not look like a crossbite, but all teeth are lingually inclined. Now, what happens to the load angle in this relationship? Well, if we add bone and we tip teeth in, they're loaded. How? They're not loaded along the long axis. So you get all kinds of issues, including recession of the lower teeth. But the forces on the lower teeth are in the wrong angle, in the wrong direction. Now, how do you get overjet? Well, if the low tongue posture results in the tongue pushing forward, so as the tongue drops, it pushes forward, the upper front teeth are forced forward, and the lower lip drops back behind them, resulting in an overjet. So this is typical of the kids that you see where the teeth are outside of the lower lip. That's simply the tongue posture where the tongue pushed forward and pushed up against the upper lip. We use a very detailed clinical template at the office to record sort of step by step what I see with each patient, and it sort of follows like this. We typically record the Panorex findings, any other imaging, and then because of photos, we take photos of everybody. I'll comment on posture, or if there's a forward head position or anything like that. Muscle evaluation and joint evaluation, and then you go through upper and lower arch proportions, then tooth position, function, so recording overbites, overjet, midline shifts, canine and molar classification, any cross bites, open bites, or tooth inclinations. And then any signs of parafunction like tongue scalloping, cheek scalloping, tooth wear, recession, tooth mobility, fremitus, and abfractions. And then just go through typical range of motion. And then occlusal analysis. So I'll look for loss of vertical, signs of retruded mandible, malocclusion of any kind. Lack of contacts is an important one as well. Lack of anterior guidance and lateral interferences. Anywhere there's lateral interferences, many of these patients have muscle pain. And then leaf gauge test on what I suspect is a healthy joint, so no signs of degeneration, to test the muscles. Type of patient that I see fairly frequently suffering from TMD is a patient that had bicuspid extraction for braces in the past. So what happens is when you have a child that has bicuspids taken out and braces put on and teeth aligned, a lot of the times the teeth are retracted or retruded, and that causes the mandible to get locked in and get retruded as well. Very often, these people will have a displaced disc and pain and clicking. So take a look at those patients that have TMD symptoms and see if bicuspids are missing, and ask them about the history of ortho, because a lot of the times you'll see that patients with bicuspid extraction will at least have clicking or popping and will definitely be symptomatic. This is one that I've seen a couple of times now, and I've seen, this is mostly obvious. I treat mostly adults. I don't see a lot of children in my practice or teenagers in my practice, but I've seen a few cases like this where orthognathic surgery was done, but they didn't consider the condylar position. So this is a patient of mine that I saw recently, and she reports that she's had symptoms for about 20 years now. She has headaches and severe migraines, neck and shoulder pain and tension, clicking in the jaw joint, ear ringing, fullness, and pain. A lot of vertigo for years now. And she says she clenches. We always ask patients, what have you tried to treat your symptoms? She's had a splint or a night guard. She said it made her feel worse, so she stopped wearing it. Her doctor referred her to an ENT. ENT said there was no significant findings, but no imaging was done. She saw a chiropractor who made her much worse, and she said that after her adjustment, she was so dizzy she could not get up for 3 days. She's tried massage. It doesn't work, but it feels good. So we also always ask about the history of ortho and any other related dental treatment other than splints. So she said in her 30s, so 20 years ago or so, she had braces. The click started shortly after the braces started. The option that she was given was to extract teeth or do orthognathic surgery to advance the mandible. Patient chose surgery. After surgery, the clicking got significantly worse and patient developed pain and vertigo. Patient went back to the dentist who did the braces, and he recommended Invisalign to solve the issue. Patient agreed, did about 1 year Invisalign. Symptoms were getting progressively worse. This is fairly recently now. And then she had, over time, she developed upper left recession and she became symptomatic. So the dentist or the periodontist recommended a gingival graft. Patient agreed, and the gingival graft was just completed 4 weeks prior to coming to see me. Patient continued to feel worse. She decided to stop the Invisalign treatment and was recommended to see me just to get a second opinion on what's happening with her jaw joint. So this is her just a few weeks ago in my practice. And what I want you to take a look at is this is actually where the graft was done recently. So it was on the first bicuspid on the left side. And it's the reason I'm pointing it out is it'll become fairly important in a minute. But I also want you to notice that there's a midline shift to the left. So she's shifted over to the left. Now, also take a look at where her canine is on the bottom and the mandible on the right-hand side. It's really shifted over to the left as well. And notice generalized recession and abfractions throughout the entire posterior. Now, the other thing to note is that the mandible is wider than the maxilla. So essentially, her maxilla is actually slightly too narrow. So the relevant clinical findings, she's got a bilateral click in the jaw joint, which suggests disc displacement with reduction. She's got muscle twitching when asked to clench and slide laterally. It suggests interferences. Upper arch is more narrow than lower, so that's one thing that I'm going to be looking at when it comes to treating her later on. Her midline is shifted to the left by 2 millimeters. The right, the canine is in class 3. The molar is actually in class 3 as well. On the left, her canine and the molar are in class 1. And this suggests the mandible's rotated to the left. That's where she can bite down. So she's got generalized recession, abfractions, lateral interferences. When she was asked to slide laterally to left, she has a heavy interference on the first bicuspid with muscle twitching. This is why she's got recession on that tooth. This is why she ended up getting a graft. She didn't need a graft. She just needed this addressed sooner so that she wouldn't cause the recession to happen. She's got immediate twitching. She's actually unable to slide at all to the right. She has severe posterior interferences in all those teeth, so she can't even go there. Okay, so on the right, she can't even slide at all. She gets stuck and just ends up twitching. This suggests that the mandible is locked in and patient's clenching to get herself out of there. And that results in the recession and the abfractions. So I see this all the time. I see anytime there's lateral interferences, anytime there's recession and abfractions first thing I'm going to look at is the lateral interferences. Is there something that is causing those, or is there another reason for it? Because a lot of the times it is just a tooth hitting too heavy that's causing these. So let's take a look. Before I show you the CBCT of her jaw joint, I just want to remind you of a normal jaw joint in a closed position, nice space all around the condyle in good shape, all rounded, nice bone around it. Now, so here's the healthy, normal, and then here's hers. So her CBCT, very narrow joint space, like non-existent, flattening of the condylar head, subchondral sclerosis, erosions, subchondral cysts. She's in moderate degenerative joint disease. Here's her left side. Again, very narrow joint space, non-existent in the distal, flattening of the condylar head, distalized condyle, severely erosions, again, moderate degenerative joint disease. So how did she get like this? Well, let's take a look. I mean, if her jaw joint, she had clicking after the braces, so she was obviously, the mandible was distalized, so it was pushed backwards, so she's developing clicking. So now she's getting some minor symptoms. So she bites down, she develops a click, so her mandible is retruded. So she starts to get symptoms, mild symptoms. So now we've got a retruded mandible with disc displacement. So what do? They keep her there. They don't correct the mandible position, and they end up sectioning the jaw and moving it forward. But they leave the condyle and the disc in that relationship. So what happens over time, muscle always wins. And so muscle is pulling the jaw back because that's not where it wants it to be. So as the muscle is retruding that mandible, it's actually distalizing that condyle even more. So causing her ear symptoms, her vertigo, her pain. So all I did was I put her in an orthotic, in an appliance that is customized. I'm going to talk to you about that in a minute. I basically put her into an orthotic, customized appliance. It looks like this. It's adjusted to the bite that she's supposed to be in, get the condyle in the right place, get the muscles to relax. And now what I do is I actually use the 3Shape software to take a look and analyze where that orthotic should be built. So I love this software because I'm able to do a lot in just virtual world without having to pour models and mount on articulators and spend a lot of time doing that. So I'm able to see where her bite is and what I need to do in terms of treatment planning. So then when she's stable, we can, and pain free in the orthotic, I can basically show her this and say, this is where you need to be. And we need to talk about treatment options moving forward to get you here and get you comfortable. So you can sort of see how where the space is in the posterior that needs to be supported. And then sort of initial tooth contact. Her so we are now starting to talk about the treatment options in order to put her in this position and support the muscle in the jaw joint in this position. So essentially, one of the options will be to potentially tip the upper posterior teeth outward, potentially surgery again. I'm not sure if she's open to that. She's had obviously a very negative experience. So her consult is coming up. We haven't had a chance to really discuss options yet, but I do know that obviously this will be one of the options. But it is essentially supporting the condyle in this position, supporting the, giving her posterior occlusion, anterior guidance, and getting the pressure off from the mandible being retruded constantly. I get a lot of questions about muscle twitching and lateral slides. And so I just literally shot this video yesterday and I slipped it into this webinar so I could show you. I normally don't record this, so I didn't have any footage. So I just wanted to show, I have so many patients with this. So here's a short video showing what happens when a patient has lateral slides and they are stuck. So there's a lot of muscle resistance, muscle memory. So the muscle is actually twitching as they try to slide towards the right or the left. So you're going to see this. This lady is locked in. She has a ton of TMD symptoms. She's the one I showed you earlier with the bicuspids missing. And she's unable to slide side to side fully because of the muscle twitching preventing her from going there. Are you on?
Yeah.
Okay, so very slowly slide to me. Hold it right there. I'm just going to pull the cheek back. Okay, and open. Let's do the left side. And tiny bit away from me. Hold right there. Watch the lip right there. And open. Good stuff. So you can see that as soon as she goes to slide, her muscle is actually aware of the lateral interferences and is fighting it, so it's twitching. So speaking of interferences, this is a patient who came to me fairly recently, and she reports jaw pain, muscle tension, and constant headaches. She had told her dentist about this for quite some time, and he made her a splint, which didn't help. And after years of telling her she's not flossing enough, her dentist referred her to a periodontist who wants to do surgery followed by grafts. So this hasn't happened yet, but she's sort of coming in for a second opinion in terms of her jaw pain, but also wanted to know sort of what I thought about the flossing and the surgery and so on. And so here's her pan. And what I want to point out, just like at first glance, is that she's got very localized areas of bone loss. So her upper right, upper left, and lower left have significant bone loss. Actually, upper right is like severe and upper left is severe, but they're very, very, very localized. And these are the areas that the surgeon wants, or the periodontist wants to do surgery on. So if you take a look at her bite wings, she's got upper right first bicuspid, upper left first bicuspid, and upper left first molar, and lower left first molar, all severely impacted by these odd little pockets or big giant pockets of bone loss. So if we take a look at her occlusion, and it ends up being all related to her TMD symptoms. If you take a look at her first bicuspid, which has the severe bone loss, if you look at the models, because I did a little bit of analysis with articulating paper on the models, you can see that the upper first bicuspid is hitting very heavily on the lower second bicuspid on the lower right. Now, we know that lower teeth are meant to be hitting on the buccal cusps, but the upper teeth aren't. So if you take a look at the dynamics, and if you consider the fact that lower teeth are supposed to be in occlusion on the buccal cusp, but the uppers aren't, you can see where it would make sense that if the upper tooth is hitting heavily on the buccal cusp, it's going to make the tooth rock, which is what's contributing to her bone loss. The tooth is literally moving as she bites down and clenches on that upper tooth. And so you can see that the buccal cusp of the upper right bicuspid is contributing to the bone loss. Now take a look at this. The upper left first bicuspid is hitting on the lower left second bicuspid. And again, the lower left second bicuspid is the buccal cusp, which is supposed to take the load of the bite, but the upper one isn't on the buccal cusp. So again, we're seeing signs of bone loss on the upper, but not on the lower, which is typical. Anytime you have an interference on the cusp that's not supposed to hit heavily, you're going to see some sort of residual signs or symptoms, which is the bone loss in her case. And so here we go. The upper left first bicuspid on the buccal cusp is making it rock side to side, causing the bone loss there. And look at the last tooth. So here we go again. Lower left first molar hitting on the mesiolingual cusp against the upper second bicuspid palatal cusp, and the second bicuspid on the upper is supposed to have the load against the palatal cusp, and the lower molar is not supposed to be rocking side to side from the lateral interference on the lingual cusp. And so again, you've got the bone loss on that tooth. So again, very, very, very consistent with interferences in lateral slides. And this lady is definitely a clencher and a just very tiny side-to-side grinder causing all these symptoms. And all I did was a very quick equilibration on the models, very messy models, but you can see the difference between the first bicuspid on the top, which is before I touched it, and then the equilibration on the bottom. You can see the leveled off teeth. Same thing on the left side. Did the same thing on her. Now what I do when I do equilibration is I actually coat the models with nail gel. So anybody who gets their nails done, you know what I'm talking about. So I use nail gel, colored nail gel, because it's really, really helpful when I mount it on the articulator and I can adjust it. You can see, now this is a different patient, so just showing you, because I didn't do this with the other one, but this one essentially just shows you if I were to do equilibration on her, what it would take to get her into the optimal bite that we were talking about. And then you can show the patient exactly what you need to do, how much you need to do. And then you can say, is this something you want to consider? Or could we talk about other options like ortho or whatever else might be the solution in that case? But it just shows you the ability, it gives you the ability to show the patient exactly how much you're reducing, where you're reducing, in a very visual way. So I really love this method nowadays. So this is pretty much what I do anytime I have to equilibrate. Okay, so management and treatment. So I get this question all the time. How do you create a template, or how do you follow a flow chart to treat these patients. And well, there is one and there isn't one. So it's kind of like in steps. So essentially, first step is always phase one for me is to resolve the symptoms. So we put the patient into an orthotic custom designed and adjusted to their bite, their slides. So every single patient's going to be different when it comes to the adjustment of these appliances. What we want to create is some anatomy. We want to make sure that they have anterior guidance, so canine and anterior guidance, so that the posterior teeth don't hit when they go side to side. In this case, you can see that the very last molars are not even covered, and that's partially because the teeth were so close to touching on the top. I just didn't want to leave the orthotic so thin that it would break. But like I said, every patient would be different. I literally could not imagine fabricating these in a lab. I had so many issues in the past with sending these out to a lab. I'm so grateful to have the 3Shape software and the 3D printer because I'm able to custom make these appliances for every patient and not have any issues. I mean, when I look back in the past, when I had to rely on labs, and a lot of the times the orthotic would come in or the night guards would come in completely different from what I asked. So there was just a ton of adjusting or a lot of remakes. I'm just so happy to be able to do this in my own office and print it. And if I don't like it, I can reprint it very quickly. So it's just a really great way of fabricating these appliances. But essentially, this is sort of what it looks like. We want canine guidance, disclusion of all the posterior teeth, switching over to the central incisor. So I don't know if you can see it here, but literally the central picks up the contact when the canine gives up. And you can see the clearance of all the other cusps, tooth shape in the back. So here's a quick workflow for an appliance like that. Raise the surface in the posterior. So I always do this. I always go from canine to the halfway back to the second molar, smooth it out. 3Shape software, amazing canine guidance. You can just add it, take away, adjust, whatever you need. A lot of the times I'll just add, make sure that I have the contacts that I need to maintain the occlusion. And again, the software is just amazing to be able to give you a really customized result. You can go lateral excursions, articulator function, you switch to lateral slides, adjust as needed, and you're literally creating the anatomy in the orthotics. So you're literally just using the software to create the shape in the appliance. So now you're really, really customizing the appliance to what the patient really, truly needs to maintain their bite, protect the condyle from severe loading, really get the muscles to relax. Anytime I have buccal interferences, again, I'm going to take them out. So you can see here where I'm removing any kind of buccal, upper buccal cusp interferences, trimming out any of the other lateral excursions. And then that's it. The appliance then gets 3D printed and delivered into the mouth. So it's just a very simple way of helping these patients manage the first phase. Phase two is customized. I mean, it could be anything. It depends on the patient. It could be multi-phase, could be single phase, could be all at once versus in multiple steps. I mean, every single patient's going to be very different. It will include every single aspect of dentistry. I've combined all of it: ortho, restorative, surgery, full arch, full mouth, surgical, perio, calibration, anything and everything. It is truly never the same with TMD patients. And it really depends on where they end up, where they're comfortable, and what they're willing to do to get there and stay there permanently. That's ultimately the end game. And then once restored, that I do an annual check to make sure the bite's stable. If they have a general dentist for their general care, if not, then obviously we'll see them every 3 months for routine care. But if they do have their own dentist, then I just basically want to just make sure the bite's stable and they're symptom free. So we'll just do a quick annual checkup. TMD is like a puzzle. You want to know what you're looking for and what it means. You want to understand where it came from, tie it together with a patient's symptoms, want to test it with an appliance, give them treatment plan options, and then just restore. So one more concept before I show you a few cases. So CR to MIP shift. So essentially choosing whether to use an appliance or equilibrate the patient. So especially happens when there's malocclusion that's not corrected. So a lot of the times I'll see patients who've had dental work that either introduced interferences or removed certain contacts. So if you have an occlusal interference where MIP, maximum intercuspation, causes displacement of the condyle down and forward, so they're biting forward, this forces the lateral pterygoid to contract. So it has to hold the mandible forward, and so it's constantly active, and this can cause muscle pain. So a really simple test is to see if this is an equilibration case in a healthy joint, or if you would be doing an appliance, is to basically test this patient with a leaf gauge and separate the posterior teeth to allow the TMJ to completely seat up into CR. So place the leaf gauge in. These are old slides, so they're a little bit rougher, but just kind of the concept is the same. So place the leaf gauge, seat the condyle, relax the pterygoid muscle, and now you've got, basically can find out whether there's a shift from CR to MIP. So anytime you have a posterior tooth contact first, that will cause the mandible to slide forward, and that requires the lateral pterygoid to actively contract to pull the condyles down. So this kind of does this movement and causes significant wear in the posterior as the patient goes back and forth between this position and MIP, so CR and MIP. A lot of these patients will have significant wear in the posterior. They can have tooth mobility, fractures, and I'm going to show you a quick case in a second. So they're kind of doing this. So this is why anterior appliances are contraindicated in a joint patient or a joint dysfunction patient. So because they increase that joint loading. So if you place an anterior appliance in, you're essentially allowing the mandible to slide forward and back and seat that condyle. So the condyle is already damaged, or if there is inflammation or disc displacement, you're going to cause pain. So in a displaced disc, we want to avoid loading. So you don't want an anterior appliance, and you're not going to test it with a leaf gauge if you already know there's a disc displacement. All right, so place the leaf gauge in. Mandible can move horizontally as the condyles seat. And like I said, if the joint is not healthy, you won't like it. So here's a patient that was having a lot of muscle pain, but she also, and you're going to see it in a second, had a ton of wear in the posterior. Once we get the patient into CR and there's no pain, then we simply remove layers of this leaf gauge until you get your first tooth interference or tooth contact. And so here it is. Her second molar hits the upper second molar, hits the lower second molar, and then she'll slide forward. And you can see the significant wear on that tooth. You can see the contact marking, as well as the tooth in front, which has actually already broken off a cusp, the distolingual cusp, where she was constantly grinding. And this is where her muscle pain is coming from. So if you actually prep this patient for a crown, let's say you were going to do 2 crowns, which is what we ended up doing to restore those 2 teeth, then you are going to run into the risk or the potential that once you prep these 2 teeth and then she goes to bite down and now there's nothing interfering, if this was truly the very first tooth contact, she's automatically going to slide backwards and allow the lateral pterygoid to relax. And then when you go to bite down again, or when you go to place the crowns, you're not going to have enough occlusal space. And these are the patients that when you prep, all of a sudden you see the crown and it's the only thing touching, and you end up over reducing the crown to accommodate the bite. So this is where it's really important when you see posterior wear and fractures to test this so that you don't end up running into trouble. So that essentially I just simply equilibrated her into CR and then restored in that position. And that eliminated the muscle pain at the same time. So here you go. This is sort of what she was doing. She was grinding on those posterior molars sliding forward and breaking cusps and wearing right into the dentin. So if there is posterior wear, especially in clenchers, and there's pain when the elevator muscles pull the condyle into CR, all forces are loaded onto the molars. And this is a big issue if the patient clenches and presses during sleep. So you're going to have significant posterior wear. And this is really the most common type of muscle pain in TMD patients without vertical loss. So definitely look for posterior wear in patients that you know, in fact, have healthy joints, but are having muscle pain. All right, so let me just show you a few quick cases. So this is Carolyn. This is her pan, and take a look at the difference in the condyle on the left side versus the right side. So there's a past injury, and the condyle just didn't quite develop fully. Also take a look at the remodeling. She's definitely a clencher, and the stylohyoid calcifications. And then take a look at the fact that she's missing her bicuspids. So a lot of these patients, I mean, pretty much a lot of the TMD patients that I see have had bicuspids extracted and have been retruded. And so we end up bringing the mandible forward a little bit. I take a lot of photos trying to line up the wear facets to see what the patient's doing. So the middle one obviously isn't the case, but the left and the right bottom ones are lining up the wear facets to see where she's grinding and what she's doing with her jaw. So here's her upper and lower, bicuspids missing. So this is an older case. I used to do this with a fixed orthotic, and I would just build up the posterior bite with acrylic. Actually, this is like a photo taken right after, so I haven't even removed the flash along the gum line. And this is the initial stop that I would use in order to build the case. I'm going to show you that in a sec. So this is where her bite was built to. And this is her with just basically onlays, porcelain onlays on top of the teeth. So the way I would do this is basically just pick a tooth that's my stop for the bite. And in this case, it was the 3-7 or the second molar. And then just go quickly through the design process. Well, very broken down, but she's in a fixed orthotic or was in a fixed orthotic. So there's like the bite was being held here. And so we're basically creating a stop. I'm going to do, so now that we have the 7, I'm going to do the 6 and the 5. And they're just very, very conservative preps. And you can sort of see them here. And then you would basically design in your 3-shape software. And there's your next 2 teeth. And there's your bite there. So then you go to print or mill. And then you go to the next one. So you do the other side. Here's my bite. Mill that. Double check the bite. And then we go the 2 finals. And again, just very conservative margin. The bite's being held with this one. Here's our other 2 onlays. And then basically mill, get in the mouth, insert in the mouth, and go through the bite check as with everything else. So the next patient's Tanya. She came in, this is her panorex. You can see stylohyoid calcifications. And if you take a look at the left condyle, it appears to be altered as compared to the right side. So that's one thing that would make me want to do a CBCT and just take a look at what's going on. Now, here's a little bit of her history or information. She originally came in due to jaw pain. And her TMJ questionnaire, she reports jaw pain, clicking. She has history of getting locked closed. She's in constant pain from what she says clenching. She has difficulty chewing, limited opening, and thinks that she's grinding on the left side. So what has she tried in the past? She's seen an osteopath and was told that her sacrum is locked, and that's what's causing all her jaw pain. So then she's had acupuncture, but said that she could not eat after, so she didn't try it again. She saw a chiropractor who apparently did a jaw adjustment. She said she felt pressure, but no improvement, so didn't go back. And She's had a night guard given by her dentist, but it makes her feel worse, so she's not wearing it. And she has history of ortho. She had bicuspids extracted. She says she wore elastics for quite some time. She had braces, and she said in total it was 3 years. So here's her left side CBCT. And if you take a good look at the left side condyle, it is posteriorly positioned. It has a very narrow posterior joint space. It's flattened, and there's subchondral sclerosis, and there's also some beaking starting on that condyle. All this suggests a disc displacement along with the clicking. So here are her internal photos. And me just sort of saying, just slide a little forward so I can sort of see where the lower jaw sits and how it looks. And take a look at the lingually inclined upper teeth. And then she's got a crossbite on the left side, and she's got a slight midline shift. But take a look at the jaw, the mandible, and the rotation in it. So she's also, it's hard to see on this photo, but she does have a class 3 relationship on the right side for both molar and the canine. And when asked to slide to the right, she has a interference, a non-working interference against the second molars. So bicuspid's gone, and really not a whole lot of wear. Small mandibular tori starting to form. And here's in her initial orthotic. You can see that I didn't try to correct the jaw rotation initially. I find sometimes the muscles really fight it, so I just positioned her balanced occlusion and let her wear that for a week, and then brought her back, and then we corrected the rotation, and essentially she was pain-free, symptom-free very, very quickly. So what are her options long term? I mean, essentially it's either ortho or a combination of ortho and restorative. We want to, I mean, if you take a look at her upper jaw, it's more narrow than the lower. I mean, I hesitate tipping posterior teeth too much, but I would like to see them tipped out a little bit more just to kind of give her a better inclination. So that would create and potentially correct the crossbite on the left side. Keeping the midline where it is, that would definitely lead to a better relationship against the posterior teeth. So that would sort of be my option. And this is what we just had a conversation about. So she understands that with ortho, there's still the potential of some restorative if the teeth can't potentially align exactly where I would want them to. So there might be, small restorations on lace potentially in her future. But I think we can do a very nice conservative job just with ortho. So that's what she's going ahead with, understanding that there may be some minor restorative after that. This patient is interesting. She came to me with severe, severe, severe pain on all types of medications for anxiety and depression due to all this pain, and just had seen everybody in the world for treatment and nobody was able to help her. She had a severely retruded mandible, very deep bite. So here she is biting down. Here she is in that estimated position. And then this is her profile biting down, very first appointment or consultation. Forward head posture, you can see that. She's got a lot of neck pain and back pain as well at this point. Headaches, just overall pain in general. This is her in the orthotic at her 1 week follow-up. And this is her now. Essentially, I just want to show you a step-by-step of how we do this. This is, I typically, if I'm doing uppers and lowers, I'll start with the uppers to get a correct alignment, curve of Spee, curve of Wilson, all that, work that out first. So this is just me trying to get a general idea of what we're going to do. This is a very basic wax up. I'm not, putting a lot of detail or time into this, just trying to get an idea of what she will look like when when she's done. And then we position the lowers against it into that position that we've established she's really comfortable in. And then we would, if she has to do it in stages, we would put her in a lower orthotic. This is just me sort of trying to adjust it to close it up a bit. And then do the lowers to go and match against the uppers and then equilibrate everything after. So this is the process in 3Shape that I do in order to essentially build to that bite. So we establish the bite, we capture the bite in with a scanner in 3Shape, and then we go ahead and essentially pick one tooth as a stop. So the first molar is the stop of the bite, and then the other 3 teeth are done to maintain that bite after that. And then essentially this is all her uppers, tweak the occlusion. You can adjust it in 3Shape really well. And then final restorations, mill, place. And this is her initial, and then this is the orthotic, the initial orthotic that we had her in. Sorry about the blue. I think she was eating something and we kind of didn't notice when we took the photos because we were so excited that she was literally pain-free within such a short time. So we just literally sat this case. So these are very preliminary photos, very messy. I still haven't even done any polishing or anything. I just wanted to grab a quick photo and take a look. So uppers against a lower orthotic. She's traveling for 2 months. So when she comes back, we're going to do the lower. So in the meantime, I just want to protect the bite and maintain her symptom free in the meantime. So she came in pain like this. She's halfway done, but no pain. And she was literally symptom free within about a week in her original orthotic. So great case and just like super happy patient after all these years. And one of the things I just want to mention, when I get patients who've been in pain for so long, I want to make sure that they're off all their medications that were related to their pain. So we always kind of talk to her doctor and just go, let's go off the meds. Let's work on a plan to go off the medication because I want to know that she's not still in pain in some way and masking it. One last case to show you to tie everything together. And this is somebody I just saw for a consult the other day, brand new patient, Emily, young girl, and she brought her Panorex with her, or a copy of it. So here it is. Not much going on, a little bit flattened condyles, a little bit of stellate calcifications, maybe a bit of remodeling of the bone, but nothing jumps out at me. And she's in severe pain constantly for, I think she said 8 years, something like that. She's been in pain for 8 years. She's been to a number of dentists and TMJ specialists. She's not gone outside of medicine and dentistry, so there's not a lot of other alternative therapy in her past, but she's had numerous appliances, some of which she brought to show me, and I have photos of them that I'll show you, and we can talk about it. And I want you to think about what's going on with her as I show you her photos, and think about how you would treat a patient like this, like what it is that jumps out at you and what you would be recommending to her right off the bat. So if you look at her retracted view, and sorry, they're a little fuzzy in the back, but you can see that the upper and lower molars, all posterior teeth, are very, very lingually inclined. No wear, really, there's no wear on her teeth. She has her bicuspids, but what do we notice? We notice very narrow arches. She's had ortho, and this was one of the first appliances that was given to her for pain, and it's essentially an NTI. And then she was given a lower Essex type retainer, and she doesn't know why she was given it. I have a feeling that she was given it to potentially prevent or reduce the chance of the posterior teeth over erupting. I'm not sure if you can see in this photo, she did end up cutting part of that lower appliance off the posterior teeth because she said it was bugging her cheek or something like that. So she sometimes wore the lower, she sometimes didn't, but she wore the upper, as she puts it, religiously. So over time, it really wasn't helping her as much as she was expected. And so she ended up getting into more pain. So this appliance really didn't treat her pain. So now we're thinking, well, why wouldn't this treat her pain? She's probably a clencher. And one thing I want to point out to you is a large open bite like this is an indication or potential indication of something, so that we want to be looking out at her vertical height as well. And she stated that she really didn't get better with this appliance, but continued to wear it. And then she progressively got worse. She said her pain got worse and worse and worse. And this was the next appliance another dentist gave her. Now, what I want you to notice is that she is locked in. This is that typical splint that we often see. She was told to wear it with the lower retainer, which is interesting as well, or lower appliance. So she's got both in her mouth, and she was told to wear both at the same time. But this is really locking her in. So if she were a grinder, for example, which I don't see a lot of indication for, she would be locked in and probably have some additional pain with this appliance. And she said this appliance is really not comfortable at all. TMJ specialist gave her this appliance. And one thing I find interesting with this appliance is it literally reproduces her actual occlusion, her current occlusion. So it literally has all the same posterior contacts that she has on her own teeth when she bites down. It creates similar open bite or space in the anterior. And so what it's basically doing is duplicating what she's doing with her own teeth, except it's opening up her vertical more. Now, I said to her, this is likely not comfortable for you, but I have a question. Is it a lot more uncomfortable than your just natural teeth biting down? And she said, yes, this is the most uncomfortable appliance I've ever had, and I'm in so much pain when I put it in. So this is a clue that potentially her vertical is actually too large. And just measuring a few things and kind of looking at the way the teeth are inclined, I asked her about her original appliance, the NTI. And I said, how often, and I asked her about the initial appliance that she got. And I said, since you started wearing it, have you noticed an increase in your open bite? And she goes, yeah, as a matter of fact, I did. So the appliance that she's wearing religiously is causing an over-eruption of those posterior teeth. And she did say that she doesn't always wear the lower, and she has cut it off. So keep in mind that she has cut off the back. So the lower molars are likely erupting, opening up the vertical, causing more pain. The other thing I asked her, because this is, tipped in, this is something we talked about early on in this webinar when I mentioned Airway and all the different ways when the tongue drops, when the child is developing, and the cheek muscles winning the war of tooth position and pushing the teeth in. And I asked her if she had issues when she was growing before the age of 10 with her adenoids or tonsils. And she said yes. And as a matter of fact, I had so many problems when I was a child, I had to have the adenoids and the tonsils taken out around the age of 8. So now you can sort of see and tie it all together that this whole thing started with likely some allergies as a child, the airway having the tongue drop in order to compensate and get air into her. And so then the buccinator muscle wins, pushes the teeth in, and causing the bimaxillary convergent relationship that we talked about early on in the webinar tonight. And then as she grew, potentially developed some muscle pain from clenching because of the lateral interferences between the posterior teeth. The initial appliance that was given to her was on the right track because it was addressing the elevator muscles and trying to calm them down. The problem is she was probably already a little bit too opened, and then the appliance, as she wore it, created more eruption of the posterior teeth, opening up her vertical even more, and then resulting in more and more pain. So how do you treat her? What do you do? What kind of an appliance do you make? Well, there's no appliance you can make. She's too open. We need to close up the bite, realign the teeth, load them on their long axis, and make sure that the posterior contacts are balanced out across the posterior teeth. Create some canine guidance, so she needs ortho. As an adult, she'd either be a surgical case or a ortho tip out the teeth type of case. And we talked about different options. And looking at her upper arch and lower arch, they're both narrow, but the idea of tipping out some posterior teeth, she's really open to that and just realigning the bite. So what we're going to do is just widen her upper and lower arch by tipping teeth out, positioning them in a more idealized occlusion, getting her to even contacts in the posterior, building the canine guidance. By pushing out the upper and lower teeth, ultimately her vertical will close and the mandible will rotate back into position. And then we can just equilibrate the bite if we need to at the end. But that's pretty much all she's going to need, is just to correct the tooth position and close up the bite a little bit, close up the vertical. TMD patients can be extremely complex, difficult at times, challenging, and extremely, extremely rewarding. I love doing this kind of thing. I look forward to going to work every day. Every day is different, every day is unique, and I just find that these cases are very exciting, especially when they go and improve very, very quickly. And it's just something that I encourage everybody to just learn more about. I'm learning every single day, and just really enjoy and pay attention to what these people are saying. A lot of what they tell you will actually give you a lot of answers. Wish you all the best, and thank you very much for sticking out with the 2 webinars with me.